Good morning, everyone. We'll call this meeting of the Health and Human Services Finance and Policy Committee to order. Today's date is Thursday, February 6th, 2025. Today's agenda, we're going to have a discussion on our emergency medical services coming from a number of different sources of information. So I look forward to what we have ahead of us. And if Senator Seeberger would like to start us off with an update on the Emergency Medical Services Task Force. Welcome to the Health and Human Services Committee.
Thank you very much, Mr. Chair and Madam Chair. I'm delighted to be here to talk a little bit about the work we've been able to do in the field of EMS over the past couple of sessions. We had a phenomenal EMS task force that met was it last year? My time has no meaning right now, but I believe it wound up at the end of last year. We went across the state. We heard from various EMS agencies to hear about the challenges that they face and the ways that we at the legislature can try to start making a difference with regard to how pre-hospital care is delivered here in the state of Minnesota. We heard a lot of the same concerns, regardless of whether we were in greater Minnesota or suburban areas. And it all comes down to staffing, the ability to get paid for the work that we do out in the field, and keeping people on the job. And the reasons for that are different depending on if we're in greater Minnesota or we're down in Rochester or we're at my lower St. Croix Valley Fire Department. But it all boils down to the same problems that we're seeing. So the task force, and one other thing, people were really, really, really grateful that we came to listen to these problems. In the community and in my industry, I don't know, everybody probably knows right now, but I'm a firefighter paramedic. In my industry, people have been very loud for a very long time about the problems that EMS is facing. And so there was a sigh of relief that finally somebody was listening and somebody was trying to do something. So the task force was great. I hope that we can reconstitute it and do the task force 2.0 to continue this work, to continue to follow up on some of the things that we've implemented and try to learn from them. We did implement a sprint medic model. We created 2 innovation zones, one in Otter Tail County, one in St. Louis County. And I think it would be important for the task force to continue to monitor that, follow that, learn from what's working well, what's not working well, and maybe how can we tweak and make changes that would benefit other services throughout the state of Minnesota. I will say, change is hard. Sometimes people don't like change, and there have been a few sour grapes throughout this process that I think is normal to any process, but I just wanted to highlight that in my particular work, it has filtered down to my employment. One of the director of operations for my particular service, not Lower St. Croix Valley, but the other service that I work for, was integrally involved in the EMSRB, and I think had a difficult time accepting the change, and that has filtered down to my work. It has had, I'll tell you an example. We had a mandatory employee meeting, which I've never had, where the supervisors sat down with all their employees, and part of the corporate slide deck was how there were ominous new changes coming to EMS in the state of Minnesota, which means that this particular company possibly wouldn't be able to sustain their ambulance and everybody could lose their job. And that's been the poisoning effect that's filtered down to me in my particular work. That's fine. They can try to do that. I will continue to try to make EMS better in the state of Minnesota. But I just wanted to let you folks know that this has not come without a personal cost to me. I'm also aware that some of the lobbyists here that were not in favor of this change actually made campaign contributions to support Representative John Hewitt's opponent in the latest race. So the sour grapes persist, but we're going to continue to listen to the folks in Minnesota, the EMS providers, and do the good work that we're striving to do, and I believe we are doing, to make EMS better in the state of Minnesota.
All righty. Thank you, Senator Seeberger. Members, any questions for her on the work of the task force? Or she answered them all with her presentation. So, well, thank you very much. And with that,
Could I just ask, Mr. Chair, Senator Seeberger, can you talk a little bit more about whether the pilot program, is that all completed and then they have to just go back to what they were doing before? Is that how that pilot works? Or can you just comment a little bit more about the kind of the arc of that program and whether there's any like residual effects that will stay in place, or if that just is a defined period of time?
Senator Seeberger.
Thank you, Mr. Chair and Madam Chair. Yeah, I'm happy to. The pilot program is just getting underway. It's going to be a 2-year process, so it just started here this year. It started recently, put it that way. And what I've heard from Senator Rasmussen has filled me in on how it's going in Otter Tail County. And from what I understand, initially there was a little bit of hesitation or tentativeness as the various agencies tried to figure out how do we work together. But it turns out they work together very well. So the hesitation at first, like I said, change is hard, but once they got into it, it sounds like it's going pretty well. I don't have the latest information on, what's going well, what's not going well, where do we have opportunities to improve this. The idea is going to go for the next 2 years. So we need to follow up with that, keep in close communication with the Otter Tail County Services and the St. Louis County Services to find out, is this working, is this not working? I will point out that a lot of agencies throughout Minnesota are trying this alternative response model. I just read an article in yesterday's paper about, I think it was someplace in the metro that's doing the same thing. Is it Edina? Is it, I can't remember. But I know Bloomington is doing an alternative response model. Roseville is doing an alternative response model. So this is something that agencies are organically developing to try to get at some of the issues that we're seeing in EMS today.
Thank you. Senator Wickland.
Thank you, Mr. Chair. And so has any of that led you to work that you want to see move forward this session? Or do you have other things that, even from the task force, that you can foresee wanting to see move forward this session? Thanks.
Senator Seeberger.
Thank you, Mr. Chair, Madam Chair. Yes, we're still thinking of alternative response models. We're still thinking of things. If it's not a sprint medic or alternative response, is there some other form of telemedicine we can incorporate into this system? So it's sort of a long-range vision that we're working at piece by piece. This particular session, I think the most immediate need is money. Unfortunately, the state doesn't have a lot of money, but I think there are ways that we can continue to support the way that EMS is delivered community by community. I will be presenting a bill to try to get at some of those shortfalls. One of the things that we need to focus on, and Representative Backer was talking a lot about last session, was reimbursing services for runs where no one is transported. In EMS, you only get paid if you bring someone to the hospital. And those of us in EMS know that a lot of the calls that we respond to, we don't take anybody anywhere. We treat them on scene and then we leave. They sign a release and we go. So that's free work. We're not getting paid for that, but the agencies are incurring the costs of the personnel and the equipment and the operations side. So Representative Backer had a really good idea last session to try to create a pool of money that would help services reimburse them for treatment on transport runs, and I think that's something that's worth considering this session.
Thank you. Anything further? Good. Anything else? Doesn't look like it. Thank you very much for joining us this morning.
Thank you.
Next up, we have Dylan Ferguson, Director of the Office of Emergency Medical Services, to bring us an update on what's going on there. And looks like you got some slides to get hooked up
I
here.
do, Mr. Chair, and they were provided to Committee Administrator Burke. Hopefully they work their way into your packets, but if not, they are posted digitally.
Okay, well, I think we do have them, so we're good there. So once you've got that ready, we'll just start from the beginning. If you would identify yourself for the record, and then you can proceed with your presentation. So welcome.
Thank you, Chair Udke, Senator Wicklund, members of the committee. My name is Dylan Ferguson. I serve as the director for the newly formed Minnesota Office of Emergency Medical Services. This morning, I'm here to provide you some general updates related to the new office's structure, its stand-up, in addition to providing you some updates on the various aid programs, including the alternate response model pilot, which was discussed in the last testimony from Senator Seeberger, in addition to highlighting some of the future plans that the office has in moving forward, not only through this year, but also in years to come. So one of the items that came out of the EMS omnibus bill from the last legislative session was changes to the way that EMS's regulatory structure operates in Minnesota. Formerly, as many of you know, EMS in Minnesota was regulated by an entity referred to as the Emergency Medical Services Regulatory Board. That was an institution that I had the privilege to serve as its executive director for just under 3 years. The Office of EMS has been created. It was created by legislation, House File 4738, and now the governor of Minnesota appoints the director of the office, as opposed to appointing the 19 different board members which previously constituted that organization. I typically don't get into matters of opinion or the why, just because those can vary from individual to individual and their perspectives. But I will highlight that that action did come out of work that had previously been done by the Office of the Legislative Auditor, looking at information of the statewide EMS system as a whole, in addition to EMSRB's operations prior to my arrival as its executive director. So the legislation that created the office did take a somewhat unusual step, and it was very prescriptive in the way that the organizational chart for the new organization would be laid out. Underneath the director, which is the role that I fill, I created 3 separate divisions. Each division is required to be led by a deputy director. And the way that I simplify this, we have a division of EMS doctors, we have a division of the organizations that provide EMS, and then we have a division for the people who do that work. So an organization division, a people division, and a doctor division. Under each of those divisions, there is an advisory council. So there's an advisory council of EMS physicians. There's an advisory council that advises on issues of ambulance service and organizations, which is really multidisciplinary. Everything from 3 members of the public, social worker, membership of representatives of all of the major industry associations, including the Fire Chiefs Association, the Ambulance Association, in addition to representatives from 2 local government groups, namely the League of Minnesota Cities and the Coalition of Greater Minnesota Cities. From the People Council, or the Labor and EMS Provider Advisory Council for long, that is made up of members of organized labor and labor organizations from emergency medical services, the fire service, in addition to, once again, representatives appointed by the CGMC, the League, and also with 1 appointee from Minnesota's 8 EMS regions. So as it relates to those deputy director appointments, I'm happy to inform the committee that we handled 2 of those with internal promotions. Charles Choucheret, who previously served as our field operations manager, was promoted to the deputy director of ambulance services, and Ms. Patty Forsberg was promoted from compliance supervisor to deputy director for the EMS provider division. As it relates to the appointment of the state medical director, who will serve as that deputy director for the EMS physicians, I was actually informed yesterday that that position description has finally been classified and approved by State Human Resources, and I hope to have that position posted for open applications very soon. Also, though, related to the advisory councils, all 3 of them met last week. For their first set of meetings. It was required that the first meetings occur before February 1st, and that was done January 30th and January 31st at our offices. They all provided valuable insights, several ideas related to different items that will help us in establishing the new statewide EMS strategic plan, which is also a requirement in legislation for a work plan to be created by myself and my office and updated on at least a biennial basis. Related to general transition, though, my focus to date has been on minimizing disruption. I wanted to ensure that, any transition really maintained the efficient and the quality service, which had really started to improve over the course of the last 3 to 5 years of EMSRB, and continuing to build on those successes and trying to maintain as much continuity in day-to-day operations, so not as to cause confusion or unnecessary heartache or concern related to those day-to-day operations, because certainly it is a sensitive issue. I am sensitive to that. In addition to wanting to do what is best for the system, the system has to be able to function with trust and collaboration. You may have noticed going through the governor's budget proposal, there is a small budget request from the Office of Emergency Medical Services. I'm working hard along with the staff in our office to implement all of the components, all of the different changes which were identified in legislation, and to do it as efficiently as possible. The small increase which was requested for state fiscal year 26 in the amount of $35,000, and then $70,000 in state fiscal year 27 and beyond. And in terms of what we were looking at for that, kind of allocating some other funds to address headcount issues, in addition to increases that we've seen for purchase services and contracted rates, are what is driving the nature of this particular request, which is something that I am very sensitive to, given the fact that the budgetary forecasts are from November of what we've all seen, and trying to also be sensitive to the future forecasts that we expect to be forthcoming from Minnesota Management and Budget in February. One of the items that also came out of the last session related to the Emergency Ambulance Aid Program. This was a program that took $24 million in general funds and distributed that to ambulance services meeting certain qualifications across the state of Minnesota. It did so via a formula-based approach. 40% of the funding was based on the square mileage of an ambulance service's primary service area, with entities that have, having larger square mileage, more area to cover, less economies of scale, were provided a higher dollar amount on that basis. 40% was then based on the number of EMS responses for calendar year 2023. This was basically a sliding scale, which placed more weight on entities that had smaller call volumes, because they don't always, in the fee-for-service environment in which EMS operates, if you do not have volume, then it is difficult to be able to generate revenue. Yet they face very much of the same similar costs as larger organizations but maybe just not always to the same scale. And then the final 20% was a base amount for each organizational entity. And then that 40, 40, and 20 was used to disperse that 24 million. Overall, it was a very smooth disbursement process. EMSRB and now Office of EMS continues to work collaboratively with the Department of Revenue, who was ultimately charged with actually making the payments. But they were wonderful to work with. We provided them advisory calculations, and it was a very collaborative process. And we have heard a lot of feedback, very positive from ambulance services across the state, very appreciative for the assistance that will help some of them be able to stop from closing their doors this particular fiscal year. I did include a link in the presentation and in the packet that you can click on that will show you the exact amounts that were given to each individual ambulance services. I do have a hard copy here today if any members have specific questions for ambulance services that they represent. And in terms of what the funding can be used for, it was specifically earmarked for operational and capital expenses. There was a specific definition for operational expenses. So we created detailed guidance on those acceptable uses. We've provided that to ambulance services across the state, continuing to field questions, offer technical support. If you have an interest in reviewing what that guidance is, once again, there's a link included in the presentation, and I do have a hard copy if members have questions. The things to highlight with this funding must be spent or encumbered, i.e. earmarked by December 31st of 2025. We continue to work with Department of Revenue on what the final reporting guidance is going to look like, and spending reports will be due back to the Office of EMS no later than February 15th, 2026, and then at a subsequent time, we will prepare a report for submission to likely the tax committees having jurisdiction, but certainly would share that with the chairs of our oversight committees as well. In terms of at a very high level, the aid distribution by our EMS regions, I will highlight that $1 million went to ambulance services serving the 7-county metropolitan area, whereas if we look at northeast and southwest Minnesota, we see that those figures are $4.6 and $4.2 million. And that was a legislative and a policy decision focusing the majority of that aid on rural areas which are truly struggling. I will not sit here and say that the larger metropolitan agencies are not struggling, but in this particular, when these particular discussions were ongoing, there was very much a rural need, and this program did answer that call. In addition to the $24 million, there was a legislatively directed grant program of $6 million. We've already talked a little bit about this Sprint paramedic program going to Otter Tail County, which incorporated grant, in addition to St. Louis County. I will not dwell on this topic as Becca, who will follow me, is far more well-versed on the operational elements in which you may be interested. But from a process perspective, Otter Tail County's grant was executed, I believe at the end of November, early December. They have expended $300,000 from that grant in terms of purchasing the necessary capital equipment to get underway, and they are preparing to go live with operations. I am still awaiting a finalized grant application from St. Louis County, and I will just highlight that this funding is available for this purpose through June 30th of 2027. And then in terms of future plans for the office and for the statewide EMS system as a whole, we've already talked about working on our formation for our statewide EMS strategic plan to identify what those different needs, both currently and future, are going to be. In terms of funding, Senator Seeberger did speak to it, but our focus is going to be on supporting and trying to inform efforts to ensure that EMS is sustainable across the state. And trying to identify ways that we can try to support the EMS cost of readiness. Particularly in those rural areas, expenses are being incurred 24/7, 365, but as many in the EMS industry will tell you, revenue is only being generated when wheels are turning from a scene to the hospital. And then also, you know, we had, under EMSRB, we had started to quantify some of the costs and the expenses of the EMS system at the ambulance service level with collecting required cost and expense information. And that work will continue under the Office of EMS on an ongoing basis so that we can continue to provide reports not only to this body, but other legislative bodies across Minnesota. There are two rulemaking projects which are currently underway. The first is looking to update our ground ambulance vehicle standards. These are our construction standards. The current version, which is an administrative rule, is actually from 1983. It is impossible to even buy an ambulance that would meet that specific standard. It would have to exceed it, which is fine, but it's a necessary housekeeping update that's been vetted by State Ambulance Association, State Chiefs Association. There doesn't appear to be, you know, any significant resistance or concerns with that proposal. And then the other proposal that we are looking at is providing some additional medication options for basic life support ambulance services through the variance process, which is established in rule, particularly related to one medication, allowing them to give it via a different route, which will have some potential, very minor, but some cost savings nevertheless for ambulance services who choose to. And then finally, our focus on what is, my opinion, the most important component of our EMS system, our EMS workforce, continuing to work to quantify recruitment goals based on current needs throughout the system, looking to protect our EMS workforce with beginning data collection related to violence against EMS providers, and also looking to document ambulance crashes, and both of those to help better inform future policy decisions, both from the executive branch in the Office of EMS and also to help inform legislative policy. And then we continue to support different various education and scholarship programs, which have been particularly fruitful with the paramedic scholarship program that was introduced in the last session. That went through the Higher Ed Committee and was administered by the Office of Higher Ed and earmarked $5 million for paramedic scholarships. And I will say to date, that has been a very successful program. Almost 300 scholarships for individuals going from EMT to paramedic being issued by Office of Higher Ed. And I would just want to compliment them because they were tremendous to work with throughout that rollout and implementation process. So Chair Utke, that will conclude my testimony, and I stand for any questions.
All right, thank you very much. Members, questions or comments for Mr. Ferguson? Senator Kupek.
Thank you, Mr. Chair. I think I'll just make a comment. I was a member of the EMS task force. And it's been really very nice to work with Mr. Ferguson here. He has done a great job. I think Minnesota's got a great gain that we picked him up and added him to our state. Just to kind of highlight a couple of things, particularly the fact that ambulances do not get paid for non-transport. When they show up and if they can triage something on site, that is a huge savings to hospitals, to the government, to insurance companies, that they don't have to go back to a hospital with that and incur those fees there. So the fact that they are not being made whole for those runs, bad on them, and they're saving us money. So we should find a way, certainly moving forward. I know there's federal legislation to do that. Medicare, Medicaid reimbursement rates from the federal government are terribly low. That would help rural and urban ambulance providers to make them whole. And particularly it is those rural EMS ones, because at least if you were running an ambulance service as a hospital, you are not making any money at that, but you do maybe take that patient back to the hospital. So maybe you get something back there. If you're a rural volunteer EMS provider, you don't have a hospital. And if you don't, those reimbursement rates are just never, ever, ever going to help you out. And in terms, we, for whatever reason, we do not include EMS workers as like critical, vital workers, the same way we do police and fire. And if you think about fire departments, rural fire departments maybe make, in some cases, a handful of runs a year, but rural ambulances are out and getting up at 2 in the morning. And our rural population is aging, and finding those volunteers, that's a huge commitment. So, a big thank you to all of those volunteers giving up, going out when there's a wedding or a birthday and you've got to go on a run to go help, save basically a fellow citizen. So that work is just goes without saying. And just to talk about the money, so I have one rural ambulance service in my district, and I think they got somewhere in the range of about $88,000 for them, which was great. And right as they got the money, one of their ambulances went down. And the cost they got a used ambulance, and I will say Sanford was very good and helped them out with some of the putting equipment in the ambulance. It didn't even come close to what they had to do. The amount of money, what it even, keep snow tires or whatever on those things. It's a huge cost for these small communities. And eventually that falls back on taxpayers because we're not making whole in these small things. So just to highlight a couple of those things. Again, thank you for your work on this. I think we're moving in the right direction, but there is more to do. But thank you.
Thank you. Any further questions, comments? I've got a couple questions, and I don't know, it's been mentioned, I think Senator Seeberger mentioned it when she was talking, and you have too, the calls when the ambulance goes out and they end up just treating the person on site, and then you return and there is no revenue generated. Do you have a number at all of what percentage of your calls across the state result in those type of non-revenue runs?
Chair Udke, thank you for the question. So as it relates, Minnesota runs approximately between 600,000 and 700,000 911 ambulance responses every year. So for 2023, because I haven't finished writing the 2024 report yet, there were 608,224 emergency-based ambulance responses and requests. Of those, from a statewide perspective, approximately 25% from a statewide figure do not result in transport to a facility. Now, those are statewide figures. I will say very much depending on the socioeconomics of a particular ambulance service, primary service area, or certain delivery models, that figure can fluctuate significantly. So, local experience may vary. It may be higher, it may be lower, but at a state perspective, we're seeing about a 75-25 split. The additional context that I would add to that is that Minnesota Medicaid will provide will provide a small amount of funding for those if certain criteria are met. However, the Medicare absolutely will not pay will absolutely not pay anything for non-transport. And there are any number of insurance plans that typically, when they're looking for whether or not we're going to pay a charge, typically default to what the Medicare guidance is. So for Medicaid, there is a small segment that there is payment for. Medicare, there is not. I know that the EMS task force did push the Minnesota congressional delegation pretty hard in their visit to DC last year. And it is a case of so it also very much depends on what that mix is at the payer level, right? So it could possibly be that that figure could be higher for Medicare, and that would be primarily one of the drivers we'd be looking at, but also for the third-party insurers. So, but at a very general level, 75-25 split, Mr. Chair.
Alrighty, thank you. One last thing, I understand there's a statewide plan that's to be put together. Any update on that as far as a timeline or where you're at in the process?
So we got initial information from our 3 advisory councils just this last week. We also undertook kind of a SWOT analysis, if you will, with each of those councils, identifying what those that are doing the work every day felt were the strengths, the weaknesses, the opportunities, and the threats to the system. And it's my plan to, already have started work of trying to start putting all of that into the hopper and trying to parse through those along with the other ideas that we have in the office. I don't have a defined time frame for you at this point, Chair Utke, just because that work is just getting underway. But I will highlight that the legislation also does require ongoing reports to the oversight committees, including this one. I do have to submit a report back to you by February 15th of 2026, and then every February 15th thereafter to ensure that I'm updating these committees on the activities of the previous year. So I certainly hope to have a more defined time frame in the immediate future, and certainly would be willing to share that with you and with Senator Wickland as well, sir.
Alrighty, thank you very much. I don't see any further questions or comments, so we appreciate your time and update this morning. Members, next up we'll have Buck McAlpin from the Minnesota Ambulance Association. Welcome to our committee.
Yeah, morning, Mr. Chair and members. Buck McAlpin, Minnesota Ambulance Association. I'm going to focus on probably some of the legislation we worked on around workforce and funding. Mr. Simonson will come up behind me. The Ambulance Association, along with other groups, worked really close, and I really have to thank the Greater Cities Coalition that really looked at this from a rural issue of what we do. One of our strengths in Minnesota is about 85% of the entire EMS volume Mr. Ferguson referred to are really transferred and provided by the 8 large healthcare systems. Those large healthcare systems also sometimes at a loss. Just recently, the McGregor ambulance had to close down because of staffing, and North Memorial took that over from Aiken. And they take that as kind of a loss leader just to be sure there's a commitment that there's EMS coverage. So as we work on funding across the state and workforce, we continue to partner with everybody to try to make sure that we're filling those gaps. But I think one of the neat things that we worked on that Executive Director Ferguson referred to, that paramedic scholarship program. In all the years I've been down here, I've never seen such an impactful tool train so many paramedics, and we think that close to 100 of them will be out in the field that have finished that from the 23 budget session. There is a report coming to the legislature from higher ed. We have a call tomorrow with higher ed to walk through the details of what that found, and we'll ask the higher ed committee this year to try to extend that funding again into the next biennium, even with the tough budget year because it's been so impactful. Volunteer education reimbursement, there's a little bit of money that sits with our EMS division every year that's not spent. We actually added first responders to that. One thing last year in the bill that passed with the big funding package was some flexibility to use different types of drivers in rural Minnesota. First responder drivers, a driver classification, that's been really successful. But we've never allowed the EMS division to reimburse first responder training. And I know this is important to the fire chiefs as we talk to them in rural Minnesota. And that's something that we'll have in legislation coming forward here. That should be introduced probably on Monday as jackets came down. And that just expands that program to try to get more people in initial emergency medical technician classes and in the emergency medical responder driver. One thing new we came up with this year is like a scholarship program. That'll probably also go through this committee and be managed by the EMS division, is to offer for some of the smaller services to bring on maybe with a full-time person, somebody to help coordinate the ambulance and train some new EMTs on site and pay for that the first few months while they get involved with the ambulance. And we thought that would be best managed through our Office of EMS. And it's a EMR, like a pathway appropriation of what we're doing. Maybe that ends up in labor too. We're not sure yet, Mr. Chair, but we're talking about that. And then we're also we have a bill drafted up for a Medicaid rate increase. Senator Kupik referred to the Medicaid rates. Our problem in rural Minnesota is 80% of the volume is Medicare and Medicaid. So 8 out of 10 rides, and even in the metro with our big EMS systems, we see that type of payer mix. Every time the ambulance goes out, they lose money on those calls. And the cost shifting component of that is only so much that you can deal with. And so we'll have a Medicaid bill, because I think as conversations are taking place around sustainability funding that Mr. Simonson will talk about after me, or the Hospital Association's idea around directed payments or other forms of funding, is there a way that we leverage money into Medicaid rates, and that kind of lifts the boat across the whole state. And I will say there's been a commitment from the larger healthcare systems that as bills are introduced to fund rural EMS, you're seeing some of the larger metro areas or the Duluth, Rochester's, Moorheads that have high ambulance volume exempt themselves out of that bucket. And Medicaid rates obviously help a lot more in that conversation than getting a check. But I will echo what Mr. Ferguson said. That money last year has kept some ambulance services in business, to your point, Senator. And we would probably lost 3 or 4 of them last year without that money you put together at the end of session. And most importantly, to Senator Seaberg's comments, treatment in place. Rebecca will come up and talk about the pilot program up there with Chase cars. Grant funding goes so far, but we have to figure out a way. And I think from a payer perspective, boy, if we go out and telehealth and treat folks outside the hospital, when we talk about hospital boarding, everything that backs up in a hospital, we're just overwhelming the hospitals. I look at Hennepin County Ambulance, I work close with too, that does 8,000 runs a month. That's unbelievable, right? That's the kind of volume that all comes into these trauma centers in the metro. And our paramedics and EMTs will tell you it's just a volume issue. So we have to figure out different ways to keep them outside of there and be paid to do that. And that's kind of what we're working on for this session. So we hope you'll probably start to see some of the bills introduced in the Senate Monday now. And now that the House is formed, after today, those bills will come in and we'll start to have hearings to move them forward. But again, all the years I've been down here, this legislature has always stepped up and supported EMS statewide. And we just want to say we appreciate it and look forward to working with you on more solutions.
Okay, thank you very much. Members, questions or comments for Mr. McAlpin? Going to let him off the hook easy this morning. Thank you very much for your update. Next up, we have Eric Simonson with the Coalition of Greater Minnesota Cities. Welcome to Health and Human Services.
Good morning, Mr. Chair, and thank you. My name is Eric Simonson, and I represent the Coalition of Greater Minnesota Cities. The CGMC is an organization of about 115 to 120 cities, all located outside the metro area. And you may ask yourself, why do Greater Minnesota cities care about this issue? And a couple of years ago, I probably would have had a different answer for you, but things have changed. The fact of the matter is that of all the primary service areas in Minnesota that are licensed for ambulance service, over half of them are owned by some form of local government, whether it be a city, a township, a county, or some conglomeration of the above. We care about this issue because our local units of government are being asked to subsidize many operations in rural Minnesota. That's been going on for a while. It's not necessarily a problem if your primary service area encompasses only your city. But imagine the city council that's being asked to subsidize an ambulance service that goes several hundred square miles outside their primary city. It's a challenge, and it's becoming a greater problem, and it really boils down to the lack of reimbursement from Medicare, Medicaid programs. That being said, we do care about this issue, and we did get engaged last year, and we appreciate all the cooperation that came together from the legislature last year. That one-time aid bill that was passed at the end of last legislative session was a huge help to many of our members across the state, and they want to say thank you for that effort. That $24 million went a long way for many medium and small services purchasing much needed equipment, the ability to place orders for new ambulances that were desperately needed, and limiting the amount of subsidy asked for from local units of government. It was wonderful, and again, thank you. We did say that we would come back to support a longer-term solution, and we intend to do just that. We spent the interim, again, working with our member cities as well as other stakeholders. The challenge, of course, as you can imagine, is finding a new source of revenue to provide dedicated funding. Obviously, there's challenges with the general fund going forward. We've all seen the forecast and we understand that. So how do we really fund EMS going forward with lack of cooperation from Medicare and Medicaid? We are working with Senator Hochschild and other stakeholders to craft a bill that not only addresses the revenue source, but gets directly to what the top challenge is, and that's the operational deficit. We know based on the 2023 reporting period, and Director Ferguson has alluded to this, non-metro services reported deficits totaling more than $30 million when you compare capital expenses plus operational expenses against their collected revenues. It's north of $30 million. We need a sustainable program that does a number of things. Address the unbillable cost to no loads or no transfers, and you've heard some testimony about this here already today. The idea that this feeds into what we're calling an operational deficit. It has to address the cost of state of readiness, which is a term that's common with EMS providers, and it's just basically kind of your base cost of what it costs for you to be there and be prepared and able to respond to 911 calls. And it doesn't matter whether it's a service staffed with FTEs or volunteer or some combination of such, there is always a base state of readiness cost. We have to allow these services to provide a service to the public that would provide the best possible patient outcomes. You've heard some testimony today about some new pilot programs, and you're going to hear more about one of those shortly. These are all wonderful things when it comes to servicing the patient and providing those services that folks have come to expect. But it doesn't necessarily help us with our operational deficit. We think it's important that whatever the legislature does next, that public funds are directed to where they are needed, in those services that actually have an operational deficit. That's a critical piece. It has to provide accountability and it has to be accurate. And we're excited that Director Ferguson and the new OEMS has stepped up to take on the challenge of doing just that. We must try to eliminate or at least greatly reduce the amount of local taxpayer subsidies outside of their own jurisdictions. Lastly, we must allow the Office of Emergency Medical Services to do their work and really focus in on how each of our licensed service operates, and we expect a lot of those policy improvements to come from that organization. We will continue to work with members of the Senate and the other body and others, as far as stakeholders, to craft a bill that works for Minnesota and invest public dollars where they are needed. Mr. Chair, I'd be happy to stand for any questions.
Thank you very much. Members, questions or comments? We can't let him off that easy. He's used to sitting on this side of the table. But anyhow, you know, and this is a comment that isn't particularly even just for your subject alone, but it kind of is across the board, and it was brought up earlier, our rural fire departments and some of the calls they make. But I know from what I see in most of our rural areas, when the ambulance gets called, particularly if it's an accident on the road or whatever, our fire departments and everybody is responding. So our rural areas are putting out a lot of money to keep people safe and do the job of, you know, the health care out, getting them from if it's a scene of an accident back to a hospital or whatever. And a lot of that isn't reimbursed because it's falling on the backs of the local governments, the cities, et cetera. So as a team, they do a wonderful job, but they're doing it on very low finances.
Right. You're exactly right, Mr. Chair.
But thank you very much for joining us this morning. Next to join us is Becca Hubish. She's the Director of Emergency Medical Services and Emergency Preparedness for the Perham Health and Perham Area EMS, and we've been hearing about this pilot program from another number of people this morning. She is going to talk to us about it. So welcome to our committee. Please identify yourself for the record.
Good morning. Thank you for having me here today. My name is Becca Hipsch. I'm the Director of Perham Area EMS, and I'm also the board chair for what we're calling the West Central Sprint Paramedic Pilot Program. We should have chosen a shorter name. So I just wanted to start out by giving a little background on why this pilot program was needed in the first place. So in Otter Tail and Grant County, which are West Central Minnesota, it's the home to 9 different ambulance services, and 5 of those 9 ambulance services are volunteer-led basic life support ambulances. And without support, they were all looking at having to make major changes in order to sustain operations. And some of those changes could have been now having to hire staff, which they could not afford to do as public ambulance services, or potentially looking at closures or consolidations. Annually, we estimate that that volunteers subsidizes the ambulance in these 2 counties to the tune of about $1.5 million in volunteer labor. And on top of that, just in Otter Tail County alone, the ambulances that have hired staff had a gap in their operational budget of about another $1.5 million. And that's not including Grant County. So these ambulances are at a breaking point, and that is not even including the cost of replacing volunteer labor. For those that don't know, when volunteer staffed ambulances are unable to fill their schedules, they rely on neighboring ambulance services to come into their area and respond to calls when needed. And this is a good system. It's a fail-safe. It makes sure that that person still gets ambulance care. But the problem is that it puts strain on the neighboring ambulances that are now covering a larger geographic region. And it also results in longer wait times for the person that's calling 911 because the ambulance is coming from a neighboring community. Volunteer staffed agencies have especially difficult time maintaining staffing levels during weekdays when they are offering $1.50 an hour for someone to stick around town and be available for 911 calls, and their other employment is asking them to show up at 8. So during weekdays, that's when we see the largest staffing gaps in rural Minnesota. Rural EMS systems like the ones represented by our program also face the challenge of large geographic areas. It may take us 3 hours to run a call that in the metro would take about an hour. We also have large areas that are only covered by basic life support ambulances. So when advanced care is needed for, say, a heart attack, a stroke, complex medication needs, or pain management, that basic life support ambulance has to request an ambulance to come from a neighboring community. They're very good at recognizing when there is that need, but there's still inequity built into the system in the fact that some people, depending on their zip code, have ALS or advanced care automatically dispatched at the start, and others have to wait for it to be requested from a neighboring community. We believe strongly that the level of care dispatch should be based on the type of call and the need of the patient and not on where that person is located. So this kind of sets the stage for why many in the ambulance industry have been looking for opportunities to innovate, and some are now taking that on themselves. But in our area of the state, where we're already hemorrhaging funds every year, we didn't have the opportunity to innovate or try new things just because of the capital costs and the setup costs and the risk that that entails was not feasible when we approached our boards or our city councils, township boards. And so without the work of the EMS task force last session, none of this would have been possible. And so we're very excited to finally have the opportunity to try some of these new models that could make a big difference in sustainability. So I am pleased to report that Otter Tail County decided to partner with Grant County in implementing this program. That resulted in 7 different ambulances coming together to create a new alternative response model. We've made some pretty good progress towards getting this program started. December 1st, we signed a grant agreement with the EMSRB at that time, now Office of EMS, to get started on the program. In the last month couple of months, we've purchased 3 quick response vehicles that are currently being outfitted with equipment, cardiac monitors, lights and sirens, and all the things that are needed to run an emergency response. We've also completed the first round of hiring of Sprint paramedics, and they are beginning onboarding and training with 3 of the advanced life support ambulances in the area. The other 4 ambulances participating in the program are basic life support volunteer-led services, and they are actively participating in our board and in designing this program so that we can make sure that this program has the intended effect of being most beneficial to the volunteer-led services. So the system will be 3 different vehicles spread across the 2 counties. The vehicles will be staffed and operated by advanced life support partners in the program, but they'll be working within the service areas of the basic life support volunteer-led ambulances. At any given time, the Sprint paramedics will be out in rural areas of the county rather than in the more central cities in the county, so that we can shorten response times and have them really embedded in the communities that they're working. When a call comes out, the Sprint paramedic will indicate over the radio whether they're in the area and whether the call type requires a response. At any time, the basic life support agency can request additional support, or they can also get on the radio and tell the Sprint paramedic, hey, this patient is fine, we've got this, and that Sprint paramedic can be available for other activities. One of our goals was to account for the downtime in this program and try to maximize community benefit. So we are engaging with our county public health departments to use these Sprint paramedics to do more community health initiatives. AED training, CPR checks, car seat checks, flu vaccines for the homebound. There are a lot of great home health programs across the state, but there are a lot of gaps in those programs too. And in the past, when people fell into one of those gaps where they needed help at home, but they didn't have it, they called 911. Our goal is to kind of route some of those patients out of the 911 system and to more preventative visits from the Sprint paramedics. To maximize the benefit to the BLS ambulances, the transporting ambulance will be the BLS agency, and they'll be able to bill for and retain the funds from all of the collected revenue. When ALS has been provided or when advanced care was needed, they'll now also be able to bill at the higher ALS Medicare rate, which can result in about $200 to $400 of additional revenue per call. These basic life support ambulances will no longer be charged an intercept fee from the advanced life support ambulance because the Sprint paramedic program is fully funded with state dollars. And that could result in savings of up to $10,000 to $30,000 per year for these volunteer agencies. So we are on track to begin operations at the end of the month. We're hoping to have the first round of medics fully trained in by that point and responding to calls. We do anticipate the need to hire a few more and train in a few more people as the program gets up and running and we fill more hours with Sprint paramedic time. We also have a board comprised of all of the participating ambulances and both counties to oversee the implementation of this program and make sure that everyone has a voice. There's a very rigorous data collection process in place, which will also be reported back to the Office of EMS and any other stakeholder group that is interested to make sure that these programs are on track with our goals and also to measure the success. Because this is a pilot program, we really don't know what aspects of it are going to be the most beneficial and what's going to work well. We know that for the advanced life support ambulances, we don't expect this to be a savings for those ambulances. We don't think it's going to solve all of the problems we're facing with low reimbursement, but we do know that this collaboration and the infusion of staff and trained and qualified personnel and equipment is going to strengthen our system in our region. So we're very excited about the opportunity, and I thank you for your time and consideration and for your action on this last session, and I'm happy to take any questions you have.
Thank you. Members, any questions or comments? Senator Kupek.
Thank you, Mr. Chair. First, maybe I have a quicker way for your name. How about the WCPPP? Does that work? There
Thank
we go. Always glad to get an acronym in there. Could you just talk a little bit about, I know, a lot of our health departments and emergency responders, they know, maybe we call them frequent flyers, that there are people that call these services a little bit more. Can you just, highlight maybe a little bit how this program will kind of help with those people that get designated that use the ambulance services a lot?
Ms. Hibbish?
Thank you. Absolutely. This is a well-known problem or situation that comes up in EMS is the frequency of callers that maybe need more support than they're currently getting at home or don't qualify for extended home health programs. So they call 911. And in the basic life support areas, these sprint paramedics will have quite a bit of downtime in between calls, just because the call volume is never going to be as busy as Hennepin County. So we are planning to have them engage with the local senior centers, with assisted living facilities, to liaise with the ambulances who know who these patients are and can begin setting up sometimes for preventative visits, sometimes just checking in, doing a set of vitals, making sure they're taking their prescribed medications appropriately. Things that paramedics are very capable and trained to do can prevent the need for a later trip to the emergency department. So a lot of the time that the sprint paramedics will be working will be building these relationships and also working with the counties who know a lot of these at-risk patients as well.
Senator Kupek.
Thank you, Mr. Chair. And one more question. And I think this kind of ties into it. I know in a lot of rural areas too, the non-emergency transport is a big issue because it takes people out of the community for hours, and maybe other ambulance services then have to backfill, and they may not get paid on those runs, and they're further, and it's a big time time constraint on volunteers. Can you just talk highlight a little bit about the issues with the non-emergency transport?
Ms. Hibbish.
Absolutely. Unfortunately, this program does not directly address the non-emergency transport issue because the sprint paramedics are not a transporting agency on their own. They'll be joining up with the basic life support agency, which does the transport and provide the advanced level of care if needed. I can share as an ambulance director in rural Minnesota that non-emergency transport across most of the state is virtually non-existent. A lot of the van services or even like taxi, Uber type services just don't exist in rural Minnesota. And people do call 911 even to get to clinic appointments, or especially to get home from the emergency department back to their residence. And it's a big issue that we're struggling to face because that is not reimbursable by insurance or Medicare. And we struggle with that cost because it's a huge amount of time that we still have to have other staff available to cover the 911 need in our communities. So very low revenue, if any at all, and high cost to provide.
Senator, that's good. Okay, thank you. Senator Curran.
Thank you, Mr. Chair. And so on that point about the transportation piece, I had the privilege finally after a couple of years trying to align with to do a ride along with Hennepin EMS. Mm-hmm. And everybody who works in EMT, the skill sets you must possess to convince the person who called you for assistance to be able to serve them and provide care is extraordinary in also crazy, extraordinary environments. But it was interesting to see, if you guys haven't done that, every single member should do that ride along. I did 6 hours on a Thursday night. And the whole series of who's using the service and what they do is so backwards. We had convenience care. It was just easier than making an appointment for a sore knee that hurt for 2 months. We had, I believe, a few of those calls were addressed, and we only went to the high priority, addressed as a heart attack, but was basically, my neighbor was mad, we had a battle, and I just wanted a ride to the hospital. And to see that, and then to understand that everybody, at least in our night, 6 hours, I don't know how many calls it was, but everybody who should have went to the hospital didn't, and everybody who shouldn't did. And it's extraordinary, and Marty Shear was spectacular. I think he's leaving soon. But to understand that it's just unbillable. And what it doesn't account for, and this is in Hennepin, is it doesn't account for every priority call we went on. There was a fire engine, there was an engine company with 2 EMS, and 3/4 of our calls had 2 police officers, sometimes 3, because of the environment we're in. And so I think, again, if every legislative member should go on that tour or the ride-along to understand, very different from, very similar, but yet different from rural areas and what they're dealing with. And so I asked them, I said, what's Thursday look like compared to any other night? Every night, every day, every shift looks the same. On the other side, those that didn't go, I think we stopped at 8 ODs, 7 fentanyl, 1 ketamine, and we essentially released them, every one of them, after a medical assessment. And I think from a police ride-along, the only difference they do is the police ride-along, they just give them the Narcan, they're good, and they send them on their way. At least they attempt to slowly administer to get some basic medical assessment done, right? Glucose, heart, breathing, after they stop bagging them and they breathe them on their own. But ironically, all 8 of them, after an assessment, they have to make a determination. Do we fight this person? Do we call the police into the ambulance to secure them for that trip to the ambulance? Or do the vitals show that, yeah, there's no underlying health care condition, and when they release them and awaken them completely, and then they become extraordinarily violent, rip everything out, the IVs and everything they have, and they just leave them out the back door. And I think people don't understand. We just dropped them off 10 feet, 15 minutes later, 10 feet from where they're clinically dead. Every single day, every single shift. And to understand that the huge portions aren't billable, just on the call side, and more or less in their environment, the number of resources, 6 resources in addition to the staffing or the infrastructure. Our areas, rural areas, don't have that, right? They're out there on their own. They don't have a backup many times from not just the medical trained, but the safety perspective. And so I think every single person, I think we should do a ride-along in Hennepin and rural too, but it is very different. It's concentrated in 6 hours. I think you get a very good view of the challenges, an extraordinary environment they have to work in with every single call. And so for us, it's really difficult. We manage from Medicaid, Medicare. You said, I think Mr. McAlpin said 80% of those calls, Medicaid, Medicare. And to be able to redirect or try to put policies together to direct people to the appropriate care. Emergency care is different, I get it. But half of those calls were listed as high priority emergencies for convenience care, because they chose not to make an appointment at a doctor's office. And I've heard the issue, well, it's hard to get in a doctor's office. Yeah, it's hard for everybody. But not everybody, when you have skin in the game and there's a cost component to it, you use those services a little bit more wisely and more predictably and at a lower cost. But I recommend everybody, if you haven't done it, everybody should do it. It's extraordinary. And by the way, they're the only business that I've ever run into, because I ask everybody, workforce, that they're doing something really, really well, because they're the only ones I've heard of. I said, what about workforce? And they said, we got a waiting list, people to join that organization. I have not heard that from anybody. And so they're doing some things really well. Every single legislator should understand that, in addition to everything that's being the conversation. It's happening all over the state in every one of our backyards. And I think the last testifier talked about the cost being passed along to our municipalities. We're going to get a good look at that in the very near future. From our counties are carrying a huge burden of unfunded Department of Human Services resources, and it's going to be compounded in the very near future. So we hope to bring some light to that. But thank you, everybody who's in that service, providing the great care you do. So thank you.
Thank you. I got one quick question, and if it's just a quick answer, that'd be great. I want to move on to the next testifier. But you mentioned a couple things, your response vehicles that you're now purchasing in the Otter Tail, Grant County areas. what's a typical response vehicle? How are they equipped? And then where do you garage them? I mean, they've got to have kind of a central rural location so that you're spread out and people are able to get to them quick.
Yes, thank you. For this program, we are using pickups for Ford F-150s that are outfitted with lights and sirens packages and strong chassis, good tires, all the things. We decided that a pickup was a better route than some of the other quick response vehicles we've used that are more like a crossover type vehicle, simply for the fact that there are a lot of bad roads and a lot of times of year that you need to be a little higher off the ground to get to patients. And so we thought a truck has the added value of being able to handle more weather and more different road conditions, even sometimes off-road conditions. Outfitting the vehicles, it generally includes equipment like a cardiac monitor, which is an advanced piece of equipment for detecting heart attacks, checking different vital signs, shocking someone's heart back into rhythm. We also have advanced airway management capabilities, pain management, a wide variety of cardiac medications and respiratory medications, and everything from cardiac arrest to stroke care to bleeding to delivering a baby, these Sprint paramedics would be able to provide.
Alrighty. Thank you very much for joining us here this morning. We appreciate the update and all the information. Next up, we will move on to our next presenter, Chief Jungman from Burnsville, Minnesota State Fire Chiefs Association. Welcome to our committee this morning. Please identify yourself and you can jump right into your presentation.
Awesome, thank you. Good morning, Mr. Chair, Madam Chair, members of the committee. I am BJ Jungman. I'm the fire chief for the city of Burnsville. I've been the fire chief there for 14 years and been in the fire and EMS services for over 25. The Minnesota Fire Chiefs Association is a professional member-driven organization committed to representing interests of fire departments, chiefs, command staff, officers, and firefighters throughout the state of Minnesota. I'd like to thank a few people while I'm here. I'd like to thank this committee and the whole body for passing law last session to establish the Office of EMS. I think that's a great first step. And establishing the advisory committees in the Office of EMS, paired with emergency aid funding and the pilot car program that you just heard about. I think those are great first steps. I would like to thank the EMS Legislative Task Force members, including Senator Kupek on this committee and Senator Seeberger for co-chairing that task force for your work over the interim and last session. I'd also like to thank you for allowing me to testify today and be involved in the discussions in EMS in Minnesota. A little bit of background for you. Minnesota is currently operating under complicated 1980s era primary service area systems where primary service areas are served by whoever owns that license. And most of the state is covered by private services, some fire departments and public services, and some areas have overlaps. And some rural areas have no coverage at all. Ironically, I just talked to a fire chief outside the metro last night, and they've had to drive their private ambulance provider in over 100 times since 2021, where the ambulance has showed up with a single provider on it, and they're provided by a private ambulance firm, and there was no arrangement ahead of this. And then when he talks to the private ambulance firm about this, they deny that that happens. So when you talk about staffing and response, there's definitely challenges out there. I would also bring your attention to the 2022 Office of Legislative Auditor. They issued a report on then the EMSRB and provided a host of recommendations. Additional recommendations were issued in 2023 and 2024, and they talked about retaining the current primary areas for ambulance services, but it should restructure how they are created, modified, and overseen. They should adopt more stringent statutory requirements for the renewal of ambulance service licenses. They should direct the EMSRB, now the Office of EMS, to develop and enforce performance standards for ambulance services, explore options for improving ambulance service sustainability in Minnesota, and potentially through pilot programs, as you just heard. And then the EMSRB should improve its oversight of the executive director. Obviously, that has changed, and the structural changes. Some of these concerns were addressed with the bill last session. However, many important recommendations have yet to be addressed, and we look forward to taking this work on with you. A group of industry stakeholders was tasked with working together to bring the legislature recommendations. They formed the Minnesota Emergency Delivery and Sustainability Task Force, the MEDS Task Force, and they agreed to only bring forward recommendations that were unanimous. At the last meeting, there was an agreement on a directive, but we are waiting a few more signatures prior to distribution, and we hope to bring that to you in the coming weeks. Simply fixing the funding is not the be-all, end-all solution. That's one piece, and the system itself needs improvement. So I'd ask you to make sure that you include accountability measures and reporting requirements for grant and aid money moving forward, and that we keep striving for innovation, as funding can't solve all and many of the issues that still exist. I would encourage you all to refresh yourself with the 2022 OLA report, and I would also ask you to reach out to your local fire chiefs and get their perspectives. As Senator Coran talked about, I know many of us would offer ride-alongs, and I think those are great experiences to see how the system is currently operating. And with that, I'll stand for any questions.
Thank you very much. Members? Oh, Senator Abler.
Well, thank you, and appreciate all the discussion. Just, I came here late, I'm sorry, but was it mentioned what the governor's proposal was to address this? Is there something in the governor's budget?
No, we haven't really gotten into the governor's budget.
But can you tell me offhand, is there something in the budget to address this, and then we'll hear about it later?
Senator Wickland.
Thank you, Mr. Chair. Director Ferguson, he mentioned the governor had a proposal. It was for small operating increase that would go into the base for them, for his office going forward.
Oh.
That's all that's been presented today as being a governor
All right, but
recommendation.
nothing statewide, so.
And that was at, what, 35,000 and 70,000, right? So
Yeah.
just a real small amount, but that's all we got touched
So-
on today.
So it's all on us then to figure out something. Okay, thank you.
Members, anything else? Questions, comments? For Chief? All right, thank you very much. And thank you to all of our testifiers on EMS. I know that amongst what we all hear, EMS is a big topic. It's in the top couple of everything that comes through our offices. So we appreciate the update and know that there's a lot of work ahead, but we appreciate everything you're doing also. So let's jump into the next section of our agenda, and we'll bring up DHS. First up, we'll have Dave Grieman, CFO of DHS. Now we've got Jeff Jorgensen, Business Transformation Officer, and Rachel Grimes. And looks like maybe it's Elise Bailey joining us too.
I'm the assistant today.
And we
Jack of all
will.
trades.
The presentation will be a report on the transformation for delivery of human services programs, the Minnesota Department of Human Services and the Department of Children, Youth, and Families.
Here I am, not knowing. Last time I used the wrong word. I don't know. Oh, there we go. Wrong way.
Thank you.
Or no.
No, yeah, you're right. Back.
All right.
Thanks.
And Mr. Grieman, are you going to start us off today?
Mr. Chair, Mr. Jorgensen's going to start us off.
Okay, Mr. Jorgensen, welcome
you.
to our committee. Please
Yeah.
identify yourself for the record and continue on with your presentation.
Absolutely. Good morning, Mr. Chair, members of the committee. My name is Jeff Jorgensen. I work for the Department of Human Services in our Business Solutions Office. With me today, I have Dave Grieman, the DHS Chief Financial Officer, and Rachel Grimes, Business Integration Director for Department of Children, Youth, and Families. So we're here today to provide an update on the Transformation for Delivery of Human Services report. Today's presentation will provide an update on the progress we've made across the 5 initiatives within the report and the 21 identified outcomes. We do have some experts here with us, just in case there are some detailed questions that members may have. So I will start with our vision, which is service delivery transformation reinvents human services by responding to the needs of people, tribes, and counties to create a better, easier experience for everyone. This vision is a multi-year effort to shift the approach with how we connect Minnesotans to critical services. It's a shift in mindset to focus on end users' experience and their needs. These efforts involve iterative development of products, including new IT tools, functionalities, and applications. And then this work isn't new. Transformation started prior to the 2023 session, and the results of some of our initial efforts showed promise, and the funding we received here builds upon several of those teams' efforts. So why are we transforming? People are at the center of our why for transformation. We learned that we need to be faster to meet the needs of our residents. We also asked our partners and communities, and they told us that we need to do a better job of listening and responding to their needs. So addressing people's pain points or challenges is the driver of our service delivery transformation effort. To address these pain points, we aim to transform digital services, change some of our outdated processes, and improve our service delivery and outcomes. And then finally, we are aligned to the Governor's Technology Advisory Council, as they are formally recommending states to move in this direction. And then we do have alignment with our agency strategic goals. Next slide. So listed on this slide are the many benefits of adopting product and agile practices. Teams from the 5 initiatives represented in this report have been working to improve the experiences of people they serve through diverse efforts. Many of the teams in the report have adopted a new approach to working that involves ongoing iterative development of products that we deliver to the end user. I'd like to share this work will be ongoing, and the measurements and outcomes will be adjusted periodically to reflect any changes or changes in our understanding of the needs of the people we serve. The performance indicators in the report are what these teams are aiming to achieve. So for the remainder of the presentation, we will dive a little deeper into each of the 5 initiatives and the outcomes in the report. And I'm going to pass it to my colleague, Dave Grieman.
Thank you. Dave Grieman, CFO of the Department of Human Services. This slide just really briefly goes through what we all know, which is that IT systems are a core function or a core part of the foundation for a service delivery infrastructure for the human services system in the state, for DHS, for our county and tribal partners, for providers, and for our clients, obviously, as well. It plays a critical role in enabling clients to apply for and enroll in benefits, to update their information, and to manage their benefits. It also enables county and tribal workers to determine eligibility, enroll the clients, and manage their cases. Ideally, an effective IT system would enable the state and counties to better target resources and interventions to meet the specific needs of clients, and integrate service delivery across programs so that people applying for benefits aren't having to input the same data multiple times, and the key folks that we work with at the counties and the tribes working with the same client, aren't having to continue to use duplicate applications and systems. And that's describing the ideal. I think historically, and I think we've been in front of this committee before in the past years, and to be frank, we've struggled with a lot of things related to updating and modernizing our IT systems. And in some ways, our aging infrastructure has not always met the needs of our clients and our partners as well. I think some of the key things that we've identified that we need to work on is we're updating, the effort to modernize and update our systems happens slowly without, and importantly, often without the continuous input of the people who actually are using the systems. Again, our partners with the counties and the tribes and the clients as well as the providers. So things were taking too long to implement and we weren't getting the right level of input. We're also experiencing a situation where we have these aging systems don't talk to each other, and which is a major source of frustration, which means people with pain points in the system often weren't getting those issues addressed. And eventually, prior to the 2023 session, or in fact, a year leading up to it, we realized we need to do something different. What we're doing isn't getting us what we need, isn't getting the people we work with what we need. So we spent quite a bit of time, DHS, also working with our county and tribal partners to look at how we can do things differently. Jeff described the service delivery transformation approach that we're using. We came forward in the 2023 session, as many of you know, with a legislative request to fund a number of key initiatives that would make significant investments in enhancing critical IT infrastructure in several areas. We worked with you all to include language that would establish 21 outcomes measures and performance measures as well to hold DHS accountable for meeting those needs and for accounting for the funds that we're spending. We're also required to submit an annual report, which is what we're presenting today, to document our progress, to track expenditures, and to monitor performance. So, and I think one of the key issues with this approach, or one of the approaches that we've taken, is changing the way we do our work. And so Jeff alluded a little bit to using product and agile methods of delivering services or completing work, which is a new way that a lot of the private sector is doing it. More public sector agencies are doing it. It's an approach we're following up on and implementing to get our work done. So what was funded? I'm not going to go through each of the proposals because we're going to walk through them separately in a minute. This was the request that we made, or this is what's the amount that was funded during the 2023 session. We're grateful for that funding. We did request ongoing base funding rather than one-time upfront funding, but recognizing that the state budget situation, the surplus was largely one-time, recognizing that one-time funding was what we were going to get, and we were happy to work with that. It's money that we plan to spend over a number of years to meet the goals and objectives of the 5 initiatives we're going to talk about today. With that, I will turn it back over to Jeff, I think, to talk about the first initiative.
Thank you, Dave. Again, Jeff Jorgensen, Department of Human Services. So all of the products and projects in our service delivery transformation portfolio are working to improve the experience of Minnesotans interacting with our programs. Ultimately, that's our goal, is to work better to serve Minnesotans. A good example of this sits within our integrated service delivery product line, which includes MN benefits, our client experience, and worker experience product teams. Our integrated service delivery product line is working to make the path to benefits simple, welcoming, and quick, while reducing the burden on county and tribal workers. Some of the accomplishments that are highlighted in the report. So in the spirit of the ongoing iterative development, the MN benefits team has made a number of enhancements to the MN benefits application system that improves the process for applicants and caseworkers that are processing applications. This includes improving how we route documents that are uploaded to reduce the volume of documents that are incorrectly routed to tribal nations. Apologize for that. Our client experience team also has started a pilot texting with 2 of our tribal nations in 12 counties. Receiving texts confirming that an application has been received and routed to the appropriate place, and an estimated wait time of when they should hear back not only helps the applicant, but it helps reduce volume of calls to our county and tribal nations. And then finally, we've held several community engagement events where we've heard from individuals who apply for services and have gained some valuable insights on the pain points and opportunities to make MN benefits better. Next slide. So all of the outcomes, the 21 outcomes that are listed in the report, there is a lot of detail. There's an outcome and why it matters, performance indicators, goals, baseline, and progress indicators. So you can find a lot more detail in the report. But for this particular initiative, there are 6 outcomes. I'll just highlight a couple of them here in the interest of time. For outcome A1, our integrated service delivery product line has focused their combined work toward the objective of reducing the overall time from benefits application to determination. And we have a wrench here, partly because we are working to establish a baseline of data. Some of the data that we have is from 2022 and 2023, so it is a bit old. And we did see a slight decrease looking at that data. Another thing I'd like to highlight is our outcome on A3 about increasing our business agility. So we focused on improving our ability to prioritize user needs and pivot priorities when necessary. So we have ongoing communication with our partners in tribal nations and people applying for services. Internally, we do that through what we call sprint reviews. And that's a place where we engage with partners and share current priorities and efforts, and we gain feedback on new features. And then we gauge whether or not to course correct to other urgent priorities. So our sprint reviews are held online and are open to our internal staff, our partners, tribal nations, and counties. And then we do hold the community events to get feedback from Minnesotans. And then finally, another thing that I'd like to highlight here is that we're focusing, A4 is focusing on making it quicker and simpler for our workers to handle administrative tasks, allowing them more time to provide services. And we're doing that in multiple ways through focus groups, user experience research, sprint reviews, as I mentioned earlier, and then individual conversations that our product teams are having with our partner entities. And then we are attending a lot of existing county and other groups like our county IT alignment and other groups where we're getting feedback. A good example of this is we created what we call our Application Status Tracker Advisory Work Group, which is a cross-section of counties and tribes and workers who process SNAP and cash applications. And so the work group is providing insight and guidance to our worker experience team as we develop our application status tracker, which will allow applicants to check their application status online. Next slide. So the next initiative that I want to highlight is our Provider Licensing and Reporting Hub. So a new Provider Licensing and Reporting Hub will create a unified licensing experience for all human services licensed programs. We have new staff that will provide technical support, training, and communication with all licensed programs. We have new resources that will support an implementation vendor, software licensing cost, and maintenance for additional technology. So some of the accomplishments that I want to highlight here from the 2024 report is that we have 2 licensing types that are fully available as electronic licensing applications. Those are our certified child care providers and our licensed child care providers. We're working to add 3 additional licenses electronically, which eliminates the need for paper applications and speeds up the process. And then the last thing is just that we've significantly expanded the team and the staff that can build and maintain these tools. Next slide. This initiative had 3 identified outcomes. The first one, our goal was that we would create personas documenting the user requirements. And so right now we've developed 5 user personas that you can see on page 54 of the report. We had set a goal of creating at least one license type to be available as an electronic application. We now have 2, with 3 more in progress. And then D3 was to ensure we had staff to work on the teams, and we have made progress on hiring staff, and there are additional staff on the way. So I believe I'm going to turn it to Rachel Grimes to cover the next initiative.
Okay. Welcome to the committee, but we've had a couple questions come up on the first portion of this presentation, so I think it's kind of a natural break. Let's do the questions while they're still current, and I've got first up Senator Hoffman.
Thank you, Mr. Chair. And thank you. I could spend all day looking through because my mind is spinning, so is my mouth. Mr. Greenman, I guess one of the biggest concerns I've had over my tenure is, probably heard me say overspending. Where's that money going, kind of thing? And some things are popping here, and maybe you could help me understand, just in the aspect of there's 44 million in the 5. I'm just going to close in on your buckets, but I do need from you a report on what kind of overspending that is sitting out there, because when the February forecast comes out, all that money, is my understanding, is going to go to the bottom line. How much is in there, right? Maybe you and I could do a follow-up as far as, I'd like that presented in front of the committee that I chair as well. But in this case, you got $44.5 million that was set for this bucket of 5 programs, 14 used, and there's that almost $30 million that's not used. Help me understand. I have 2 questions. This is just the first one. Help me understand where that not used money is right now, David. Is that, you have to know that?
Mr. Greenman?
Mr. Chair, Senator Hoffman, I think that's a really good question, and that's one of the things we wanted to address in this hearing, and I'd be happy to have a longer conversation with you about it. We certainly recognize that, as I started earlier, we had received the funding one time with the idea that we would have a period of years in which to complete the work that we're doing. I think you're going to hear about some pretty significant accomplishments we've made, but we haven't spent the money as quickly as we anticipated. There's a number of reasons for that. I think one is, particularly around the healthcare area, we have a lot of, one of the things we had to do immediately after session ended and we received the funds was start the process of working with counties and tribes to renew eligibility for 1.5 million Minnesotans. What we didn't expect quite to happen during that process was for CMS to set a number of new standards for states in the middle of that process that required us to really quickly pivot a lot of the work that we do on our MET system. So we had to get into our MET system and do a lot of the things very quickly that were really important things. They didn't achieve the outcomes of this work. I mean, I think they supported those outcomes, but they didn't actually complete the outcomes. And what we included or what the law said that we are very supportive of, that appropriated the money, is we cannot use these dollars that we receive for these projects and these outcomes cannot be used for anything else. So we would spend other funds to meet those CMS requirements during the renewal process for Medicaid. So we did do a lot of work. One of the challenges with doing work on things like METS and MAXIS and our major systems is, for some but not all of those systems, and depending on the kind of work that you're doing, you can't have 2 or 3 people in there doing it. You got to do it one at a time to fix things. So often you got to get the things done during the public health emergency renewal process. We had to get that done, and so that's delayed some things. And then I think there were a number of major pieces of programmatic changes during the 23 session, continuous eligibility for children, some tougher changes. I think there was eligibility expanded for children leaving foster care, and I know there were a handful of other ones that all required work on METS, and those were priorities as well. So things tended to get a little bit backed up, frankly. I can get into more detail on METS later, because there's a number of deadlines coming up that we need to really ramp up for. I think certainly Mr. Jorgensen talked about the provider hub. You see in there that we'd spent considerably less than we budgeted, and yet we're green on the outcomes. There's a number of reasons for that we can definitely go into. I would say there's still a lot of work to be done, so I'm a little curious. I wouldn't say we're green on everything. I think there's a lot of things we still need to do with that provider hub in terms of what licensed professions get included in it, and we're still a ways from reaching that goal. So I think we still have a lot of need for those funds, and it's an issue that I know we're going to need to talk to you about, because we just heard folks from the EMT system talk about the need for money. So we know this money's dear, and we need to spend it. We need to spend it on the right things and get these accomplishments met.
Senator Hoffman.
Thank you, Mr. Chair and Madam Chair. And I'm good, David. I understand now where it's sitting and what's protected, what's not. Because my biggest concern is, you remember 2 years ago, $1.825 billion was underspent, went to the bottom line. Was I correct on that, Abler? And so, Mr. Chair, the underspending thing, is really important to us, because when you look at the MMB's report and MMB's comments and MMB, when you look at just human services, I'm not including health and human services, you too, but human services makes up about 25% of the total budget, and 80% of that's forecasted spending, right? Yet when you look at this $1.5 billion that is in the projected budget that was being presented to us, not here, but that equals 65% of the funds are going to be taken care of to cover that $1.5 billion, 65% out of the human services bucket. And so I'm having a hard time balancing, well, how much of that has been overspent? How much, where are those hidden pieces in there? And it just dawned on me, especially on the licensing side, you don't have to answer this question because I don't want to take any more time. I'm just going to direct to the chairs. On the licensing thing, not just the two outcomes that they had, the child care licensing, but we know in the 245D world, there's licensing that takes 27 months, right? And we, as an entity, gave money to increase those licensing, but now you're seeing that there's no money being spent in that pot. So I guess questions back to the chairs on, as we're looking at this, what's our role here, you two? And it's not a question, it's more directed to you two on what do you want us to do?
Thank you. Senator Wickland.
Thank you, Mr. Chair. I was going to talk more about this later, but I think that in each individual project, I think there's a lot more information in the report about what is encompassed by a given project. So I think that needs to be considered as you think about, whether things have been completed or not. I think when we worked on these proposals 2 years ago, we worked with, there was proposals brought forward as governor's proposals for IT projects. Myself and my staff and fiscal staff worked carefully with DHS on how to make sure that the proposals were well-defined and that they were funded in a way that the projects could be completed, but also realizing that IT work doesn't happen in a year. These are complex projects that have to work, as Mr. Greenman mentioned, that they have to interact with other projects that are going on in the same systems. And so it's not realistic to say, well, we're going to give you a pot of money for a project that has to do with METS and just go off and do it, because it has to interact with all the other work that's going on with that system. And so we tried to create a structure that allows DHS to bring back to us outcomes, as they're working on these projects. We have the annual reporting, we have accountability for the use of the money, and then realizing that it has to be spent over a number of years. It's not going to be spent all in one biennium. And I think, Senator Coran and I are part of the Technology Advisory Council, and we talk a lot with, across our state government, how much technology debt we have in the state, how many old systems we have that need to be upgraded, and we have people have new uses for interacting with government. And so trying to find a way to fund major projects is a real challenge for us. And so I think you might see areas where money hasn't been spent, and I think we can ask for reasons, why it hasn't been, and we can understand what has been taking place. But I think we also have to realize that if we don't allocate funding for these projects, we can't expect them to get completed. They're very significant, require significant funds. The provider licensing hub, I think if you look in the report, it does go into all of the different licensing types that are planned for the provider hub, which I don't know if Mr. Jorgensen is able to comment on. You mentioned one type of licensing. I don't remember that, if that's going to be included, but I know the goal is to try and include all licensing types in use of that licensing hub and provider hub. So I think there's more depth on the provider hub that's in the report than what you've talked about today, but we have kind of limited time too. So, yep.
Okay, thank you.
Mr.
And
Chair.
I don't know, did you have any, it was just kind of a quick question to Mr. Jorgensen. Was there any follow-up there, or is that just something you want to do offline?
Mr. Chair, Madam Chair, members of the committee, yes, I think it would be best to follow up, but on page 55 of the report, it does show the 2 license types that are electronic now, the 3 that are planned, and then additional information, but be also happy to follow up with more detail.
Okay, thank you. Next up, I have Senator Bolden, and I would just, as we have interaction from the members to our testifiers, the clock is getting away from us a little bit, so we'll try to keep things fairly focused. We'll get as many questions and comments in as we can. So,
I'll wait till the end in case my question is answered in the next part.
okay. Actually, I've got a couple more questions first. You still want to wait? Okay. Next up, then, I have Senator Cran.
Thank you, Mr. Chair. And Madam Chair, you gave a good highlight about what we've looked at in the Technical Advisory Council as it relates to Health and Human Services and their impact on all systems, right? There's some 14, 15 ancillary systems and 4 major ones. You've got to understand, when you make a statement that, well, in 2023, we discovered we have to do something differently. Well, the users have been screaming for 20 years. And the thing that most don't understand is, for my time here, most of the counties have come to us extraordinarily frustrated, right? They're bearing the burden. They actually do the work in the front line, from the person in need to the providers. Our county taxpayers pay a huge portion of that unfunded mandate, and the ineffectiveness is continually thrust upon them by the Department of Human Services, by their lack of understanding of what they really do in their role. You describe agile and sprint sessions, all those things. That's great. They're good. Don't get me wrong. That's all good. We're still just scratching the surfaces, because what I still haven't seen, and everybody's heard the lecture in the Technical Advisory Council and everybody shows up, is I still don't think you've made the investment necessary to learn your job at an expert level in every single business unit, at the rule level and the decision-making trees, because you do have one of the most challenging burdens that exist in state government. And so without that, without you investing, and I still think it's a minimum 18 months ahead of time before you start any actual real development. Because the things you talked about here are good, right? Automate it. Our clients know their needs better than you know what their needs are. And to allow them self-service environment, those things are all good. But those are really small ancillary systems interfaces hanging on the outside of really complex systems that you have to deal with. The greater challenges are in the large systems, and we know they need to be redone. And our counties are desperate in saying, please don't inflict pain on us, because they've gone through these cycles before. You end up with 4,000 new workarounds in a new language, a new platform, and all those things, great. They bear the burden. And so without you investing the time to learn what your job is at the expert level, not in your view, but in the view of literally everybody else. And it doesn't mean shareholder meetings, having a conversation in a Zoom session when everybody's in their basements still. you need to invest your staff time, your business people in DHS in the agencies doing the work until they actually see it. Because every one of those stakeholders can tell you what they do, but they can never really tell you what they do outside of their own environment while doing the very tasks that they have to do. And so I'm still, I've seen it, 40 years doing this. You don't do it because you don't have to. And we're saying the right things and we're trying some different things, but I don't think fundamentally you're investing that time to go out and do every single job that exists. We don't have a technological problem, right, or a technology problem. We have a business knowledge and logic problem. And when it's going to be really critical when you get into the replacement of those large systems, Maxis, Metis, right, all of those, because that's where the rule definition, understanding every intricacy or interdependency, codependency, and being able to make the proper decisions as we build that out. We've got some procurement technology that we've changed in, you know, how we procure those things and gather the expertise that doesn't exist within our agencies. But that's what I don't hear. It's still the same, you know, we're working harder, we're including, we got work groups, and that's good. But it's still not managing or preparing us for the largest, most complex mission before us, which are those large systems. And we already have huge unfunded burdens to our counties, and at the end of the day, all of the ineffectiveness just means poor service for the people that are actually in need and the providers that actually do the work on behalf of the services that you guys regulate and mandate. And so I would love to walk with you. I want to sit down, talk to you about what that means. And we have to deploy training methodologies to actually make sure our workforce is better trained. We got great people in most places, but I still don't think we are moving and adapting to what you describe as a parallel in the private sector of using agile and sprint sessions, and all those things are good. But the very difference between them and us is they have baked in accountability for when they fail to understand why every job exists in every role and every position in the complex world, because it'll fix itself when you get it wrong. In our area, we never fix it. We just add more people, more money, and continually get less. And so while the technologies are analogous, our foundational approach to it is very different. And so I would love to sit and talk to you on it. I don't think you need a response because we don't have time, but that's what I don't hear. We've heard Swiss watch, right? I still feel like we're Swiss, or we're Operation Timex, or maybe even Operation Timu when we get to the end of the day from a county perspective. And so do the good things, those ancillary things hanging on the outside, love them, but I still don't think we're prepared for the largest challenge we have before us. Besides the hundreds of millions of dollars we're going to have to put in to build those systems, and the confidence you're going to be able, you've made the investments prior to getting to that point that we can move forward. So that will build confidence in us in moving forward, and so we can put those burdens in or enter that battleground that everybody's on equal ground, because only when you do that, and the county people and everybody that's on the user side, and the agency and the technology side understand that and invest in the time. Only then can you have truly mutually beneficial conversations about every aspect and need and how you can help each other to make sure that at the end of the day we get a great product. So I offer you, I'd love to sit down and talk to you after. Thank you.
Thank you. We will take that as a comment because I do want to we've got two more. Senator Abler, you were next up. We'll get a couple questions in here before the end of the day.
Mr. Chair, all I can say is we need a technology committee, and I don't want to be on it. But I think that conversation would be well suited there. Is the best I can comprehend. I'm a much simpler technology guy. I need 14-year-olds in my life. But I understand the challenges you're under. But it just seems like after all this time, and I've been here, there's still a lot of frustration at the operational level. And so, I don't know, just somebody sent a message to me yesterday, and they said, you know, why can't we allow for more administrative efficiencies to remove multiple redundant, unnecessary steps? And then they catch an error, the lead agency and contracted case manager, they restart the delay clock. So I just like, sometime tell me what's working better and what still isn't working. There's a lot of challenges and frustrations. I don't think it's that you're not trying, but maybe we can take it offline. But it seems there's some simple things that wouldn't require whatever Senator Cran was talking about. to make it just function so that at operational level, that you can get licenses done in a short time, you can scrutinize the unlicensed providers better, just on a fundamental, simple level, and then go into whatever that was. So, thank you.
Thank you. Senator Bolden, did you want to follow up with the question? Because I don't know if we probably didn't touch on what you were thinking of.
Thank you, Mr. Chair. I have two questions that maybe we won't have time for answers here, and I was thinking maybe the last part of the presentation would answer my question, but I'll just pose them, and you can either answer if we have time or follow up with me later would be fine. So my question is about the SSIS system, and we have heard as a committee for many stakeholders over the last years about the need to overhaul that, and I certainly hear that in my district as well. So I'm wondering about on page 36 of the report, it lays out some of the main challenges that you discovered in your review, and identifies 56 different recommendations for how to improve the system. And then the report goes on to say that only 16 of those recommendations are currently feasible, and only 11 of those have been scheduled for implementation. So I'm wondering about, just can you talk a little bit about why the small percentage of the recommendations are actually scheduled for implementation, and then what are the barriers to doing those other things?
Is Ms. Grime, is that yours?
Mr. Chair, yes, Rachel Grimes for the Department of Children, Youth, and Families, where I'm the Business Integration Director. I could either answer that question now, or I think I may get to some of it in the presentation, but I'm happy to add a little more detail there when I get to that part.
Yeah, Mr. Chair, I thought I wanted to hear the rest of the presentation. I thought maybe you had answered in the presentation. I don't know if I'll have time for that, but either way, would love to have follow-up. Thank you.
And I think as far as the presentation goes, we've run the clock out of time, so we may have to we did hit kind of a natural break as we went into the children and families section. We may have to invite you back for a time when we can actually give its just due time. But did you have a second question you'd like to at least get on the table so you can get a response back?
I do. Thank you, Mr. Chair.
Senator
And again, we may not have time for this, but happy to follow up later. In thinking about data and security and the importance of that, I know we take that very seriously here in Minnesota. We are hearing lots of reporting coming out of the federal government around data breaches, and Elon Musk and his college-age interns that now have access to much of information and data at the federal level. I'm wondering if you have concerns about that, if you are, because that data is connected, and we're seeing reporting about the payments through HHS and those types of things. So wondering if you have concerns about that, B, if you have seen any effects of that, but mostly just thinking about the importance of having security of data and how that impacts people having access to the services that they need and are eligible for. Again, don't know that we have an answer for that right now, but I want to put that on the table of the importance of that and the potential impacts of that. So thank you.
Anybody got a real quick response? If not,
Senator Outke, Mr. Chair and Senator Bolden, I think there's a lot to unpack in what you just said, and we're happy to follow up with more on that at a future date. I think we're about out of time. There's a lot to say, so happy to think about it and come back and talk more.
thank you to all three of you for joining us this morning. I know I too had a few questions. We'll communicate a few of those offline, and then as we, I'm sure, prepare for future meeting agendas, we can pick up what didn't get covered and bring you back so that we can hear the full transition time. So thank you for joining us this morning. Thank you to everybody else that participated. With that, we will stand adjourned.